little bit of background. This is the Kennedy Krieger Institute. Kennedy Krieger Institute is a neurorehabilitation hospital in Baltimore, Maryland, and Kennedy Krieger is dedicated to servicing children, adolescents, young adults, and some older adults who have any and all difficulty or illness of the brain and central nervous system. And the patients that I work with at the Kennedy Krieger Institute are children and adolescents with autism and other forms of developmental disability who present with very severe behavioral and psychiatric disturbance. Kennedy Krieger is very much dedicated to helping each child reach his or her potential. Many of the children that you'll see in these videos and in the images aren't going to reach the potential that you might hope for example, for your own children. But nonetheless, we believe very strongly that every child does have the potential, and that when illnesses are pushed to the side and treated appropriately, that child is more free to reach his or her potential. Okay, so I had used this little quiz question a couple of years ago in a presentation for the American Academy of Child and Adolescent Psychiatry. Since I think in psychiatry with kids, we're pretty much all on the same page that therapy is important, medications have a role, genetics are important, the brain is an important frontier in child psychiatry. I'm not sure if everybody would necessarily agree that an ECT device is an important part of child psychiatry, but hopefully by the end of the presentation, everyone will be in agreement about that. Okay, so in this presentation, I'm going to talk a little bit in the beginning about electroconvulsive therapy for children in general, not children who necessarily have a developmental disability, go over some of the standard indications for ECT, and then review what I think is one of the most exciting frontiers of ECT, and that is the use of ECT in individuals with autism, and in particularly in individuals with autism and intractable self-injurious behaviors. You're going to see lots and lots of case examples throughout the presentation. I actually forgot to mention that I don't have any professional disclosures, and you are welcome to take photos of the slides themselves, but I'd ask you just not to take photos of any of the children, since the parents have given permission for those to be shared just in professional forums. We'll talk about some practical matters, and then I think in the morning we've already heard a lot about the challenges of ECT, and we definitely see many challenges in ECT in this patient population, and I'll try and focus on some of them that may be specific to children and adolescents and those with autism. Okay. So a good place to start in considering ECT, I think, is to start from looking at the accepted ECT indications in adults. And everybody would agree that affective illness, cognitive illness, acute suicidality, catatonia, NMS, status, and some movement disorders are indications for electroconvulsive therapy in adult patient populations. And we have a lot of knowledge to support that 80 years after the birth of convulsive therapy. This is actually a courtesy of Gabriel Gazda, who's right over there. It's for clinic notes from the original therapy, the original experiences with the injection of pantolizumab in Budapest, Hungary. And I like this example because the patient who is described is a patient who has been very sick, hasn't moved for 4 years, hasn't eaten, hasn't talked for 4 years, and is completely dependent on other people to keep him alive. And then just 2 days after having his 5th injection of camphor and oil, is able to get out of his bed, talk, and ask for something to eat. A complete 180-degree turnaround and vast improvement in his baseline presentation. And I really like that image just because it just demonstrates again the power of ECT for some of the most compromised patients. This, of course, is the data from the CORE and CUC studies looking at the efficacy of electroconvulsive therapy in adults with major depression. Probably everyone's familiar with that data, but just to point out again, I'm not going to be able to make the pointer work, that one, these are patients who are very sick, so these are patients with high HAM-D scores. These are patients whose HAM-D scores dropped significantly after ECT, very high remission rates, and in a relatively short period of time. I will point out, and although I think it was already mentioned this morning, that when we're talking about depression and the type of depression that responds to ECT, we're not talking about the worried well or people who were fine last week until they had an adverse environmental circumstance. These are people who are very ill, have usually been ill for quite some time, and of course this all emphasizes the syndrome of melancholia as an exquisitely ECT responsive condition. I'm going to show you next two videos of young men who do have autism and mild mental retardation, both of whom also had profound depression as well as some catatonic symptoms. And actually before I do this is one of my favorite examples from residency. One of the first patients where I was able to view the benefit of ECT. This was a middle-aged man who was admitted in the middle of the night, absolutely miserable, like sitting on the filthy floor. Johns Hopkins isn't necessarily the cleanest of places, sobbing, his life was horrible, no good, nothing ever was going to come of his life. He removed his socks, which were really dirty, and was wiping his face and tears flowing down. And his presentation was, again, like 180 degrees different after a few ECT.
I don't want to go out the water because I'm thirsty. Brain, go away, go away. Shut up, shut up.
So I think it's obvious, even though this is a gentleman with a developmental disability, just how distraught he really is. And I've been showing that video, the Brain Go Away video, for many years, and was very happy to get a newer video, again, that shows the element of profound depression as it may present in somebody with autism. So I'll show you this one. So keep those young men in mind because those are exactly the types of patients who benefit significantly from ECT, but for whom sometimes treatment is withheld because of the fact that they have a disability. Okay, so I'm going to skip over a lot of history. There's actually a very interesting history of the usage of ECT in children, but I decided to focus my energies more today on modern examples. But in your free time, the history of ECT in pediatrics is quite fascinating and starts in the US and France. But, okay, so when is ECT recommended for usage in children today? These are the standards from the American Academy of Child and Adolescent Psychiatry that actually are somewhat outdated, but need to be updated. That hasn't happened yet. Basically, the American Academy of Child and Adolescent Psychiatry requires 3 criteria to be met. 1, that the patient would have an ECT responsive condition, which makes sense. 2, that the patient's symptoms are severe enough to warrant ECT. And 3, that the patient hasn't responded to other treatments. And specifically, and I draw your attention to this, ACAP says that patients should have failed 2 drug trials, 2 full drug trials. They don't say that you should have failed 8 drug trials or a trial of every medication that you can purchase in the United States, or that you should have been hospitalized for 3 years or 5 years. All you need to have failed are 2 trials before ECT can reasonably be considered. And those recommendations are based on the literature that we have up until now on electroconvulsive therapy in youth. These are the summary percentages from a review done by Walter and Ray in 1997, looking at all the ECT literature in youth, presenting some pretty good percentages for depression, mania, catatonia, somewhat lower for schizophrenia, but still some nice numbers for patients who are otherwise suffering significantly. I will point out that in the Walter and Ray study, they emphasized that the most common adolescent ECT complaint was a headache, exactly the same as it is in adults. Well, so you might say that's kind of old. That was in 1997. It's 2017. So this is 2016. This is just somewhat of a smaller update from the Mayo Clinic, where they looked at 51 patients who had received electroconvulsive therapy on their services over a time period of 22 years for affective, psychotic, and catatonic symptomology, and found that 77% of those patients were either much or very much improved on a clinical global impression at the end of the ECT course. Again, some very impressive numbers. Okay, so I'd like to point out we're very fascinated in child psychiatry by the latest medication that's available, and sometimes tend to fall into this belief that if you can swallow it, it's fine and it's okay. Lots of times, unfortunately, we see a lot of side effects in child psychiatry. And we never see numbers as high as what you just saw from the Puffer Mayo trial in terms of response rate for illness. So one, these are pretty good percentages in terms of response. They definitely offer hope for patients who haven't had much hope before. And then I think there's an additional element when you're working with children and adolescents who are very severely ill, in that obviously mental illness is not something that anyone enjoys at any stage of their life, but when you're working with a child or a teenager, somebody who's suffering from significant symptomology, who has been in a hospital, who hasn't been participating in what children are supposed to be doing, like learning and playing and having social and family opportunities, we think a lot in child psychiatry about developmental windows and kind of those optimal time periods in a child's life when they're open for all of that learning and social and familial those experiences that are going to ready them for adulthood. And when that patient is severely mentally ill and not able to participate in that, a lot is lost. This was one of my favorite curbside questions from hotlines. I received a call one day from the adolescent psychiatry service about a 16-year-old who had attempted to commit suicide multiple times. Prior to admission, he had attempted to self-eviscerate. Surgery had put everything back together and stitched him up. Had failed multiple psychotropics over the past 4 years, finally had received 4 right unilateral ECTs, showed some improvement, but then attempted to slit his throat and stab his mom. And the question at the time was whether I thought that bilateral ECT would be indicated for this young man. And sometimes I tend to give somewhat ordinary responses, but I had to really refrain from making a response that wasn't very nice. Because obviously if you step back just a little bit and looked at just how compromised this guy was, there really wasn't any question to be asked in somebody who attempted to self-eviscerate, slit his throat, and spent more than about 25% of his life in a hospital. So depression in adolescence is actually a significant health concern. It's estimated that at a point prevalence, about 2 to 5% of adolescents will meet criteria for major depression, and that 20% of adolescents, by the time they reach age 18, will have suffered from an episode of major depression. And similar to adults, in adolescence, there exists the phenomenon of treatment-resistant depression. And basically that's defined as lack of response to evidence-based interventions. And in children and adolescents, those would be interpersonal therapy, cognitive behavioral therapy, and SSRIs. So it's estimated that about 30 to 40% of patients respond to the first intervention, but that long-term, only about 60% actually respond sufficiently. And that leaves about 40% who remain ill. The consequences of untreated major depression extend beyond the illness itself, in that we see with these patients higher suicide rates, lower academic achievement, lower occupational achievement, and more long-term difficulties in terms of social interpersonal interactions. Sorry, the Mac sometimes misbehaves. And then suicide is not an irrelevant issue for adolescents. This is a study from JAMA that is just a couple of years old, that in a large population-based study with the prevalence of suicidal thought at 12.1% and attempts of suicide among this adolescent cohort at 4%. And significantly, it was found that the vast majority of those patients who made a suicide attempt had a DSM-5 disorder. And this was another consultation case from Johns Hopkins from the typically developing adolescent ward. And I draw your attention particularly to the quotes that I kept from this young lady. So this was a young woman, again, with major depression who had attempted to commit suicide multiple times, classical symptoms of major depression and multiple failed drug trials. And some of the quotes that she shared were that, "I don't think I will have a chance to grow up. I have almost hit rock bottom. I would rather be dead. It's time for me to go." Okay. Of course, when you hear something like that, your heart automatically breaks for a child experiencing that, like for anybody. But you can't help but not think about the amazing efficacy of ECT in the resolution of suicidality. These are just some results, again, from one of Dr. Kellner's studies, showing the remarkable response to ECT in terms of the dramatic and quick reduction in suicidality. Okay, so adolescent psychosis, I'm going to go through this sort of quickly. I just wanted to add in a few words about adolescent psychosis since this is somewhat less commonly found than major depression. Most of the adolescents that we work with who have psychosis usually have it in the context of an affective disorder. Childhood onset schizophrenia and schizophrenia in adolescents are less common, but when they do occur are particularly devastating and don't have a very good prognosis. I've had the opportunity to follow over the years the experience of a group in Barcelona who's worked with many individuals with schizophrenia spectrum disorders who either did not respond to antipsychotics, had catatonic symptoms, or developed too many side effects to tolerate antipsychotics. And they've actually demonstrated some really nice results, not only in terms of symptom improvement, comparing the two groups, so finding similar and significant improvement in rating scales, including the GAF, CGI, and PANS for both patient groups, noting, however, that neither group had significant improvement in PANS negative. And very interestingly, also did 2 follow-up studies looking at what both the patients and their families thought about ECT, which becomes really important, maybe even more so than in the adult population when you're dealing with children. And you see here that the vast majority of patients found ECT to be very helpful, would agree to an ECT course again. Same thing for their parents. Okay, so now I'm going to talk about catatonia and autism, or the new ECT frontier, which is kind of my academic baby, if you will. Obviously, you see here the images of Carl Calvin and the title pages from catatonia or tension insanity. I will point out that I've definitely learned in the past decade that all beginnings are difficult, and working in this patient population may have been somewhat like experiencing the Wild West again, in that we didn't have a lot of knowledge. We had a lot of sick patients and had to react very quickly, and we're kind of learning as we were going. And as I'll discuss a bit later, also had to deal with the ups and downs of a lot of stigma and ECT resistance. So that was my experience in the Wild West. Okay. So of course, Calvin's catatonia, I think everyone's familiar in the audience with the symptoms of catatonia, basically a clustering of discrete motor, vocal, and behavioral symptoms. And here you see some images. These are largely courtesy of Professor Shorter, historical images of catatonic patients from Europe. And then these are also some images of pediatric catatonia, which has been recognized in the literature since the beginning of the 1900s. And you see an array here of children with various catatonic presentations. You see a particularly disturbing photo in the center from France of the young man with the mutilated face. We'll talk a little bit more about him when we get more into the modern case examples. But his presentation is very important when we look at catatonia in autism spectrum disorders. Obviously, it's a very disturbing presentation. It's disturbing when we see it today, but it can't be helped. Okay. So what does catatonia have to do with autism? So actually a lot, and since 2000 there have been 4 large studies that have demonstrated that catatonia occurs regularly in autism. The first was from the United Kingdom by Rona Wing and Amita Shah, looking at over 500 patients, finding that fully 17% of them met criteria for catatonia. The next one was 5 years later in Sweden, a somewhat lower percentage of patients diagnosed with catatonia, but some interesting comorbidities picked up, including half of the patients having self-injurious behavior nearly a fifth of them being very violent or aggressive towards others, and nearly a quarter of them having tics. Then in 2012, this is from the University of Michigan. This was actually a retrospective study looking at the patient files of 101 patients who were admitted with various diagnoses, and finding that nearly 18% of those patients in the retrospective analysis met criteria for catatonia. Interestingly, prior to the retrospective study, only 2 of them had been diagnosed as such upon admission when treatment was sought, which is often an issue that we deal with in terms of the delayed recognition of the catatonia syndrome. And this is a very, very recent study, again from the United Kingdom, that was developed to look at validating a rating scale for what these researchers termed attenuated behaviors, so kind of slowed or damped down or quieted behaviors in autism. And so the rating scale that they were looking at had multiple symptoms. Of the 87 informants in their study, they found that 20% of them had already received a catatonia diagnosis prior to participation in the study. So that's our biggest percentage thus far of these 4 studies. And then using their core attenuated behaviors that kind of extend beyond the classic catatonia, so the slowness and amotivation, prompt dependence, difficulty starting and completing tasks that we also see very commonly in autism and catatonia. Using those types of criteria, nearly half of their patients met criteria using their rating scale for catatonia. So that's a pretty big number of patients afflicted. These are just images, so comparison between modern and historical images. Obviously this is a patient who's posturing with all of her limbs and with her head and with her fingers, and has the psychological pillow, except she's wearing a helmet, whereas he has the neck roll. So here's some examples of Charcot's Arc de Cercle, a classic presentation, and then on argument. And neither of those patients had any training in gymnastics, and when they were finished with their episodes, could not do that in the least. So this is an array of patient images that I put together just again to emphasize the vast spectrum of catatonic symptoms that we regularly see in our patients. You'll recognize here many patients who have classical posturing, who are in all sorts of unusual positions, upside down, doing these strange Superman poses. Clearly there's some patients like the young lady at the far side who have not eaten in quite some time and are very emaciated. And then you see scattered in here as well, patients who are highly agitated. Even though they're still photos, you'll see patients here who are trying to hit their head, patients who require attendants or multiple attendants to be on top of them to prevent them from harming themselves, as well as patients who show the physical sequelae of that type of behavior, particularly the young man in red, whose face is so swollen that his eyes have swollen shut. Okay, so this is just a summary of the types of catatonic symptoms that we regularly see in autism spectrum disorders. And I think the first ones are readily kind of recognized across the board in spectrum. Many times in patients with autism, we'll additionally see significant further skill regression. So these aren't patients who were functioning at an age-appropriate level to begin with, but may have spent years in intensive behavioral therapy gaining the skills that they did have, and then those are lost. And many of these patients will display ongoing purposeless agitation, and then the self-injurious behaviors that I'm going to go into a little bit more. But what we see here is really a range or an array. This is the same patient, and you see a range from the patient where he's stripped and is naked on the bed, posturing and unresponsive, to putting himself back and forth widely on the mattress and trying to bang his head. This is just a summary from some data that we've collected over the past 10 years in 22 patients that we've worked with on our unit. It may be somewhat difficult to read from afar, but at the bottom, this was using DSM-5 catatonia criteria, showing just how many of these patients presented with given symptoms. So for those of you who don't work in autism, the idea of self-injurious behavior may be something somewhat new. And the Band-Aid is very much a euphemism for this problem. Many individuals with autism will display negative behaviors towards themselves, towards others, or towards the environment. Self-injury is a horrible problem, can lead to significant bodily injury, oftentimes leads these patients to receive excessive medication, complete psychosocial incapacitation, and many times, unfortunately, is unresponsive to standard treatments, including psychotropics and behavioral therapies. And the stakes of self-injury can be very high, as indicated in these pictures. The gentleman there who has 2 black eyes actually succeeded during one burst of self-injury in hitting his head so hard that his eye came out and then had to be surgically removed. And I apologize for the bloody picture after lunch, but it's important to see because that's the type of repetitive self-injurious behavior that has no operant cause or nothing to do with the environment, that doesn't usually respond to methods of applied behavioral analysis, and typically is very drug resistant. But it's a bad presentation and we need a solution for that. So I'm going to go back to one of the original cases that we saw, the young man who was screaming in the room about his brain and asking for his brain to go away. And this was a young man who actually was very high functioning before he had a serious psychiatric decline starting at age 16 with multiple bona fide suicide attempts. He tried to run into the autoroute. He had tried to electrocute himself with a fork, sticking it into the wall. He crushed light bulbs and eaten the shards of glass. And he developed a state of ongoing agitation with severe self-injury and aggression, and ended up spending several years in a state hospital, literally tied down to a bed before he came to us. He also had a lot of interesting catatonic posturing when he wasn't trying to smash himself. And this was what his face looked like a couple of days before we started ECT. And this young man, as I mentioned, had been for several years in a state hospital, tied down to a bed in the old type of 4-point restraints with an additional binder over his abdomen to keep him from moving on the mattress. And very poor tolerance of psychotropics, nearly developed neuroleptic malignant syndrome on several occasions. And this is his before and after. Now, I will point out that we usually don't get this lucky after one ECT. It's usually like 3 or 4. But we really need it in this case.
Is that being out of Toy Story? No. Is Toy Story still your favorite, or is it 20,000 Leagues now? I think 20,000 Leagues. Okay. That's a great cut.
So you see the amazing, vast improvement from a gentleman who was wearing extensive protective equipment in a padded room with additional gym mats around him, multiple people trying to prevent him from smashing his head on the floor. And then now he's talking about some preferred children's movies after one ECT, while we were actually waiting for ECT number 2. And this young man, so this is an old case. He has remained in remission now for, I think it's 8 years. He has received over 700 lifetime ECT. Several attempts at weaning the maintenance ECT frequency to less than once weekly led him to attempt suicide again, and then once become completely unresponsive for 20 hours. So they're no longer attempting that. But you do see how happy and functional he is here, enjoying family activity. That was a family wedding. Okay, let me show another example, because I think the examples really bring the message home.
Alright, today was my first day of school. I've been in my room before though. Last week, Mother took me there to meet my teacher. It was called Meet the Teacher Day. My teacher was decorating the bulletin board with the letters of the alphabet. I already know all of those letters. I said, I can sing them, except I don't feel like it right now. My teacher took my hand, only our hands made a picture together that good. Her name was Mrs.
That was another case very similar. Obviously, this is a young girl who had had a massive catatonic and kind of depressive deterioration. As you saw, had literally receded to just laying on the sofa, was unwilling to do anything the entire day, crying and sobbing ongoing, not eating, and then she's back to doing schoolwork. So, actually another very recent case, this was a younger child who had started to demonstrate the same type of deterioration, actually starting at a younger age, at age 8, receded to his bed, stopped eating, lost all of his verbal and communication skills, lots of posturing, and what his mom described as getting stuck when he was moving. Sadly, before he was even admitted to our unit, because of the repetitive self-injury that he displayed towards his head, he detached both of his retinas and was largely blind in both eyes. He'd only retained a little bit of vision in terms of being able to distinguish shadows. And this is his baseline. Maybe. Well, I thought I was going to get away with the max behaving the entire time. I guess not. Okay, so basically, well, now you've seen a lot of self-injury in autism, but even without the video behaving, this young man is in what we call arm restraints, where his arms are in a type of canvas sleeve that prevent him from being able to flex his arm. Obviously, that doesn't leave a lot of function to his arms. The things are padded. He's in a hockey helmet with a face shield. He's sitting on gym mats. He has additional mats like they use for sparring and karate. And then he has this attendant who is literally on top of him to block all of his attempts at self-harm. And I saved this picture because I think it's really poignant in that prior to ECT, this was the only way that the little boy could play. So you'd think that 11-year-olds should be able to play, but the only way he could play was being put in what's called a body sock. It's basically exactly that, like a giant sock. You put the child inside, it kind of squeezes them, and then he's sitting on mats, he's leaning again on a karate mat, and his head is out with the helmet, and that was his only option for playing. You see some very early improvement with the start of ECT. This video is going to play. So he's still wearing his equipment, but you notice that he's missing an arm restraint on one arm. And he's not hitting himself in the head, he's playing with that little fishing toy instead. Okay. So like I said, we don't usually get lucky in that patients are miraculously completely cured after one treatment. It takes some time. And here you see the course of time for the intervention of ECT. Most importantly, prior to this child going home. Remember, for these children, we want them to be able to go home. If ECT can get them home and out of an institution, a locked ward, that's amazing. And you see the dramatic reduction in overall rates of self-injurious behavior at time of discharge to less than 1 per day. And what's not displayed in the graph, but what happened also during the same time was the removal of all of that stuff that he was wearing, all of that equipment, and the gym mats and the karate pads, and then the people who were on top of him. And here we have, here we go, it will play. So here we have him playing. Now, he's 11 years old. Most 11-year-olds don't put blocks in a bin. That's more like a 2 or 3-year-old skill. So true, but that was his baseline functioning level. ECT doesn't cure mental retardation, it doesn't cure autism, but that's his functioning level, that was his play. And now he's able to play again and do what a child should be able to do. And this is him just enjoying the Florida coast after discharge. Okay, so in about the last 10 minutes, I think I was allotted an hour, but I know we started a little bit late, so I don't mean to monopolize time. I wanted to just discuss some specific treatment questions that come up with this patient population. So first, in terms of ECT itself, it's important to remember that the ECT procedure remains the same. There's not a different ECT for children or for adolescents. It's the same procedure, more or less the same anesthesia, recognizing, however, that children, as compared to much older people, they tend to seize at the drop of a hat. So their seizure thresholds are very low. Sometimes they may have prolonged seizures. Sometimes they may require additional medication to stop the seizure if it extends over 3 minutes. These children, we've also seen some of them display tardive seizures, which I've never seen in the typically developing population. But again, these are children, and then children with autism have a higher risk of seizures. And I kind of term kids with autism as having twitchy brains, like their brains are just kind of ready to go. It's not difficult to make them seize. So we do have to watch out for tardive seizures. None of my patients drive, so that's not an issue, but they do require supervision throughout the rest of the day after ECT. The same neuromuscular blockade, the same oxygen. One of the best lessons of Dr. Kellner that he likes to always point out is that green gas is good, so oxygen is good for adult patients and obviously is good for pediatric patients too. Okay, probably some of the most significant issues arise in terms of preparing these patients for ECT, because these patients typically have cognitive impairment, they have autism, and going into any type of medicalized setting is scary. I'd say that for the vast majority of our patients, having an IV placed is one of the most scary things. And there's a lot of fear of procedures and bright lights, people that they don't know, a lot of sounds. We do a lot of preparation in advance of our patients with social stories, preparation of the families. For many of the children, it's difficult to understand why they can't eat. They're hungry, they want food, why they can't eat before the procedure. And then we also do a lot of preparation of the staff. In looking at its standard ECT practice, most ECT providers don't have a large number of children engaging in self-injurious behavior wearing hockey helmets coming to ECT, and they need preparation as well. So one of my doghouse mornings was related to the same patient that you saw screaming about his brain, who was very anxious about ECT, and when he arrived, took off his shoes, threw them at the ECT doctor, who ran into the other room, and then he slapped the anesthesiologist across the face. And so I had to explain that one a bit. So we do a lot of preparation now so that the team understands and can plan for these patients. Let's see, other acute ECT peculiarities. Max Fink, I've been fortunate enough to be mentored by Max for the past decade plus, and he always reminds me that not all seizures are equal. That seems to be particularly true in these patients.